Um, Good afternoon. I think there's 10 participants. Uh, some of the students and professionals I believe would join us as we go along. First of all, on behalf of AusPak, we would like to thank Shane for agreeing to take us on this lecture on the construction of obturators. A basic introduction about Shane. Shane Chambers is a prosthetist, a dental technician. He's a hygienist and a therapist. He's the owner of Shane Chambers Dental Prosthetics. He works in Townsville University Hospital, the oral health department. And he is also a clinical teacher and guest lecturer at James Cook University School of Dentistry. Yeah. Thank you, Shane, for taking us on this lecture. This lecture was a request from one of our doctors after we had our last lecture last year. Yeah, so this lecture would be the first for this year. Yeah. Thank you, Shane, and I'll leave the floor to you.
Thank you, Jebby. That's a great introduction. My name is Shane Chambers, of course, and as Jebby said, I have a private practice in Townsville, Queensland in Australia. And yes, I also work at the oral health department at the hospital. My primary clinical area of practice now is removable prosthetics. And because Townsville Hospital is actually the regional centre for oral cancer and cancer treatment in general, we eventually get a lot of these patients filtering through to the oral health department for their care. So I'm fortunate in that way that I get to see these patients. Privately, we don't see them so much. They generally come through the government system. Please feel free to check out my website, see what we do in our private practice, and touch base, make contact whenever if you ever feel the need or want to. Let's move on with the presentation. Jebby kindly asked me to come and present cleft palates and obturators to you over this meeting. It's a scary topic for the general practitioner in his everyday practice or her everyday practice, because we're not supposed to be able to see from the mouth into the cranial spaces, and can be quite confronting. So hopefully what we're going to do in this presentation is to give you some keys and some concepts that's going to take away that initial shock value, that initial shock factor, and allow you to practice safely for yourself as a health professional, but also safely for the patient. There is any number of textbooks, any number of journal articles written, and they're all very easily accessible online. But I'm hoping to impart some of the lessons that I've learned through practice to make it easier for you and make it much more comfortable part of your routine practice in the hospital system. What you will find is that a lot of the images that I've used in this lecture are directly from the internet, and you'll see the links to those websites. And that's quite deliberate, because hopefully through this methodology, we will be able to link you up with more information than I can possibly give in 1 hour's presentation. I'm a BPS clinician, so I follow the Ivoclar denture construction process. SEMCD, you may have heard of, is suction lowered dentures through Duro Arbe's teachings. And these will all play into your everyday practice with cleft palates. And you'll see as we go through. At the end of this lecture, there will be a list of take-home points. This is where the meat of the lecture will come, And if you can take away some of these points, you're going to make your practice much more comfortable and much more straightforward. What we're going to speak about tonight will include submucosal cleft palates, complete cleft palates and obturators, and removable prosthodontic clinical considerations for these cases. We will not be talking about cleft lips, whilst that's often lumped into the cleft palate discussion, and we won't be going into a great lot of detail about the laboratory processes. Very happy to come back at a later date and unpack that area, but in 1 hour that would be outside the scope of the lecture, I think. So when we're thinking about making a prosthesis with an obturator attached, the first thing we do is probably stress and think, how do we do this? Where do I start with this jigsaw puzzle? Fortunately, we're very well versed and very well educated in general removal prosthodontics. So we know that a full upper and a full lower denture should stay in place primarily through suction, atmospheric pressure inside the denture. And we know that occlusal balance, muscle balance, and base support will keep those dentures in place very well if we follow our standard procedures. We know that the partial denture for partially dentate patients will be held in place with many of the same forces being balanced, but also with the retention units onto the natural dentition. And these are things we do all day, every day in our practice. We learn this in dental school very early, and so this is something that's not too difficult for us to grasp. But your understanding and ability to practice at the base level will allow you to very easily attach the obturator without too much stress or hassle to you in that normal process. And you'll see what I mean by that. Still looking at base knowledge, we know that in the mouth we have non-keratinized mucosa. This is mucosa that covers the cheeks, the inside of the cheeks, inside of the lips. And we know that with the non-keratinized mucosa parts of the body, our prosthesis should be highly polished to prevent abrasion and rubbing on those tissues. We have keratinized mucosa, so this is the masticatory mucosa of the gingiva. And we know that with a removable prosthesis, we want to have these areas non-polished to increase the cohesive and adhesive forces within the denture. We know, as I said in the last slide, that the full denture is going to be retained by suction and seal, and we know that if there's natural dentition, we can also utilize those for retention. And again, occlusal balance, muscle balance, and base support all being considered and all being manipulated will aid and increase the retention of the denture. This is nothing new. If you imagine for a moment that you've walked into the clinic and your head dentist has said, patient in chair 2 has a cleft palate, we need you to seal this palate so that the patient can function normally. Instantly within you, there's going to be a rise in stress hormones and where do I go with this? If the minute you think of a cleft palate, you think of something like the image on the right. There's going to be a large hole in the palate. You're going to see soft tissue that you probably don't see every day, don't want to see every day. And you're wondering, actually, what do I do with this case? How far can I go with my obturator? What actually do I have to do to make this patient have a better quality of life? We start to then think of these great big balloons that go on top of a denture. We think that the obturator has to fill this space that is presented. And we wonder how on earth we do that, and does it need to be this big? What I do want to stress here with all these images is that with the obturator on the left in the left-hand image, this may very well be exactly what that patient needed. So I'm never going to criticize or question whether these images are correct or not. In this patient, this is probably what is needed. This is a great outcome for that patient. I'm not here to judge that. But it doesn't always have to be this great big massive concern that you initially will think of and worry about. We know that some of the causes for cleft palates will include genetics. There'll be potentially developmental clefts. We will have tumour removal, such as benign or even malignant cancerous tumours. And they may also have a cleft palate through trauma, motor vehicle accidents, etc. The very first step after doing during doing your consultation is to try to figure out what our treatment goals are going to be. And your treatment goal for the patient and the treatment goal for the clinician are probably going to be quite different, but the treatment goal for each patient will also be quite subjective and quite different. For instance, if you had a patient who's always had a cleft and never had clear speech because of air movement, they may not be so worried about the speech pattern at the end of their treatment. But if somebody had good normal speech and then lost it, they're probably going to have a higher expectation of outcome at the end of the treatment. So every patient's going to be different. But essentially, from my experience, patients are looking to close the cleft in their palate to prevent food from moving into the intracranial spaces. They're going to hope to improve normal breathing. They're going to hope or restore normal breathing. They're going to hope to improve their speech. And of course, they're going to hope to replace missing teeth for function and aesthetics. The clinician is probably going to be a little bit more simple in their outcomes. They want to restore function and aesthetics. They're hoping in some way to prevent iatrogenic dentistry. They don't want to cause harm to their patient. And they're also going to hope to create a stable and functional appliance. We are probably more simple because we're not quite as invested as the patient. Now, if we look at iatrogenic dentistry, the big area in dentistry in Australia at the moment is osteonecrosis. We mostly focus on MRONJ, so osteonecrosis related to medications and its effect on the jaw. But osteonecrosis is a big factor when patients are put onto things such as bisphosphonates, anti-angiogenic medications. They may have had radiation or chemotherapy. And we're talking about the patients that have had cancers or tumours removed from the palate. Potentially bisphosphonates aren't used quite as widely in PNG. I'd like to know actually the answer to that, and I'll find out at the end of the lecture. But it's quite rampant in Australia, and it's really become something we have to check with every patient at every medical history because it's so common. Now, we know that prosthetic use, when any of these treatments or medications are used, is a significant risk factor for the development of osteonecrosis. So gone are the days where we can develop an ulcer from a denture, even potentially have a sequestrum that falls off, and then the mouth will heal. If we get to that point with somebody on these bisphosphonates or other medications, we're probably not in a really good place and becomes quite stressful. So what I'm hoping is that we're not going to develop these iatrogenic dentistry outcomes. So when deciding what to speak about tonight, I've decided to speak firstly on submucosal clefts and then to talk about complete cleft palates. The submucosal cleft is probably a good place to start because it's a little bit more aligned with what we understand and know in general dentures, but it will definitely be the one that will probably catch you out, and your maxillary denture may magically not stay in place with suction, and you'll maybe not understand why because you've done everything right. So you may have a submucosal cleft following surgical correction of a complete cleft. They are often developmental, and their prevalence is less than 1% in the general population. These palates will be deep, they will be V-shaped, and they'll have a central fissure. And you may see some blue hues where there is no bone under the soft tissue, but the tissue is completely covering the palate. There may be a bifid uvula, which is usually a good giveaway. And of course, they're going to affect the maxillary bones from left and right, potentially affect the premaxilla, and potentially affect the vomer. There will be an abnormal insertion of the muscles, which will cause a shortening of the soft palate and a tightening of that soft palate. And this is one of the main areas where we have trouble with these cases. And of course, we'll get some VPI, which will potentially, not always, cause some speech and some regurgitation problems in the patient. This is a difficult case to treat because everything will seem to be going along okay. The palate will seem quite normal to you, but for some reason, you're going to have trouble getting your suction. You may not understand why that is. We also want to know, if possible, with scans, what the position, quality, and quantity of the bone is under that soft tissue. Accuracy is critical to try and eliminate some of the error in these palates. So when we're making our impressions and making our models, we have to be as accurate as possible. And we're talking about very small detail, but it's the small detail that we maybe often don't realize causes our failures, even though we feel as though we've covered the basic technical approach. So the first impression should be done with alginate. And of course, we need to ensure that we've followed the instructions, the mix and the timing of the alginate well. But we need to cast our model ASAP. And what we do need to do is ensure that when we're casting that model, we do it in a two-stage casting process. We know that we place plaster or stone into our impression, we make a mountain on the table, and we flip our model. We're not going to do that, and you're hopefully going to see what I'm talking about and why we're not going to do that. The stone or the gypsum product is pulled into your impression while you're casting the model with gravity. If we flip the impression to put it onto a mountain of stone, we're going to have the gravity pulling ever so slightly, but very significantly on that plaster and pulling it away from the impression. I won't go into the A, B, and C too much, but the key takeaway point here is if you pour your impression, cast your impression first and leave it sitting like the impression on the lower, the third impression across from the left, let that set. The plaster will move with gravity into the impression, and you will get less distortion. Once that sets, then make a little mountain of plaster to put your impression onto and make your base. Another way of doing this is very much like the beading boxing process on the left. You can make up a base and have your impression facing upwards and then place your stone on top. Now, casting the alginate straight away is important because we have V-shaped palates. And if we lose moisture content, water content out of that high, deep palate, we're going to get a lot of shrinkage of our palate, so that when we pass our impression, our model, it's going to be wrong. In the same way, if we flip that model while we're making it, flip the impression while making the model, because it's a very steep palate, you have a shear force and the plaster or the stone will actually run out of that impression much quicker. This is a major area for error, and especially with that tight post-dam area of the denture and with the steep palate, we're going to get big areas, and it's going to be more than enough to make your denture fail. Which is what I've said here. So the gypsum will be pulled into this impression surface. The gypsum particles will condense at the impression surface interface, and that will give you a harder model. Air bubbles will come to an insignificant area of the model, and you'll get a reduction in shrinkage and distortion in your final model. Small point, very important point though. And then with the submucosal cleft, it's a very straightforward approach in the standard manner. First impressions, secondary impressions, bite registration, wax try-in, and then in the insertion. The difficulties, as I suggested, were the short, tight, soft palate, the V-shaped groove in the middle of the palate. Ask your technicians not to remove that groove. It will be sharp, it will be knife-edged, but you need to be removing that in the chair. And you need to be very cautious, because when you remove that V-shape aspect across your post-dam, this is where you potentially will lose your suction. These patients do have potentially have a strong gag reflex, which will hinder you through the whole process. And of course, we want to manage how we deal with them, given their medications and previous treatments. Complete cleft palates. These are some very large cases. I didn't see the images of the patients, but I'm assuming that there's significant removal of maxillary bone and other oral structures for those two. So we have a complete cleft, and we wonder where we're going to start. We're going to start back by collecting all our known points of reference. We have keratinized mucosa, we have non-keratinized mucosa. And what you don't commonly see, but you will see in these patients, is we have and I call it a junctional epithelium, for want of a better term, but it'll be the point at the aperture of the cleft where the keratinized mucosa meets the internal non-keratinized mucosa, or the mucous membrane of the inner spaces of the cranium. This is a very fragile area. And a take-home point here is your obturator should not be rubbing or touching this area every time it goes in or taken out of the mouth. Very much like a soft tissue undercut with a standard denture. If the standard denture is continually rubbing across the height of contour of a soft tissue undercut, that denture will not be tolerated for long, because that patient will suffer from an ulcer or a sore spot. This is a major risk factor in this area. The obturator should be able to pass through that space without continually contacting that aperture of the cleft. Just as a standard denture, any area that is touching non-keratinized mucosa is highly polished. And any area that is on keratinized mucosa or masticatory mucosa is unpolished. We know that that gives us retention of the denture, or helps to give retention. And we know that the polishing prevents abrasion or irritation of the non-keratinized mucosa. If you look at this denture and this image, you can see that their obturator is highly polished. What's not quite so clear, but I think is definitely there, is the polishing goes right down onto the denture base past the aperture of this cleft. This is so that if there is any movement of the denture, it's not continually abrading that junctional epithelium. Key point. Now, I do have a box sitting over my... Yeah. So primary impressions for partial and complete prosthesis should be done in alginate. Ensure that your mixing ratios and setting times are followed. And this is really important because the next point, assess the risk of alginate becoming stuck in the cavity before proceeding. I've not had this happen to me. I don't know how likely that is to occur because when you look into this inner cranial space, actually quite wet and quite slippery with mucin, food particle, and the alginates tend to come out quite easily, but it would be a horrible scenario to be in. So assess that and make sure that your alginates are nice and firm and set completely before you start to take them out. And of course, use tray adhesive to ensure that it does stay in your tray without any distortion. This slide is a beautiful little case study that you can find online. The link is there. This is potentially something that you guys will see a lot of, and this is kind of falling right into the area that Johan was hoping I'd speak on. This case obviously has had some tissue removed, a tumour of some sort, and has a cleft in the palate, but we have a lot of natural teeth, and it's a really easy, straightforward approach. If you look at the impression on the top right in B, you can see that that alginate did in fact flow into the sinus and has locked in and has an undercut there. But if we then go down to C, in the final prosthesis, we have a bulbous, heavily reduced obturator. So that obturator will not touch the aperture of that cleft at any way, shape, or form. And it's highly polished. This is how simple your obturator needs to be in practice. And I find that my obturators are actually quite small. And you'll see why I'm saying that. Let's look at the complete denture scenario. So on this slide, this is a little practice model that I've made. And it's probably easy to understand because it's sort of pictorial. Standard design for our trays. In my practice, we use light cured bases or hard acrylic bases with wax rims attached for our secondary impression and our bite. All my impressions are done closed mouth. So standard design for me would be something like this. My obturator has a wax spacer over it, so I know it's not touching any of that red area inside the cavity, inside the cranium. And I can fit this tray to ensure that there's no contact with the internal anatomy or the aperture of that cleft. So this slide now is just showing you a few steps. So the middle image is my model. The top left, I've placed a little bit of wax into that cleft. And I'm showing you this so that hopefully you can show your technicians what you're after. All I've done then is taken some blue light cured material, tray material, and made a non-hollow cleft type appliance, obturator type appliance, and then covered it with a light cured base material to make a denture base. I've used the two colors only so that you could see that in in the images. Then I put a wax rim on top. My clinical step is to do my bite registration first, and then to go into my impression technique. The impression technique is set down by Ivoclar. Oh, we've got some movement in our image, that's okay. Set down by Ivoclar BPS system is to do our heavy body functional impression of the periphery first. In the bottom left-hand corner, you can see this blue heavy body impression around the peripheries. To do this, we place our impression in the mouth. We get the patient close into the predetermined position, and then we get them to do we put the impression in the mouth. We do a lateral movement of the mandible to get the pterygomandibular space, and then we get them to close, and we do an oo and an e movement, and then we get them to swallow. I usually do 2 to 3 oos and e's so that they can mold that periphery for us, and then the swallowing will activate all the muscles to give us a good peripheral seal. I take that impression out once it's set. I'll trim off the excess. Now, these images on the bottom left have had the impressions trimmed. So we want to leave about 3 millimeters around the edge of our heavy body. I'll also remove the freener from heavy body. I will then place a light-bodied wash over the entire internal surface, and I'm essentially painting this on with my impression tip. It's not thick, it's a wash, and completely over the heavy body periphery and completely over my cleft. I'll put that into the mouth. I'll get them to wiggle their jaw, the pterygomandibular space. I'll get them to close, and I'll do the oo, e a number of times, and then they'll give me a big swallow, and then they'll wait for that to set. When we take this out, we're going to take it out once. We're not going to put it back in. We know our bite's right. We assume our impression is right. We're going to take it out once it's set. And what we should find is that we have a good impression of the aperture. We should find that we don't have any contact with the internal aspect of the superior area of the cranial cavity. And we've got a good suction retention type of denture. Once we get our model made on that appliance using the bead-in box or the two-step impression pouring technique, we then have to consider, how do we deal with the cleft? So we have our peripheral seal. We've already proven that. But that's one seal, and in effect, you could imagine that that's sealed off the cleft, even if we didn't have a obturator, because we've sealed off the inside of the denture. As I said earlier, one of the main concerns for patients is that they get food traveling up into the cranial space. Food will get under any denture at some point because dentures move, and at some point food will pass under and it's going to end up going into the cleft. So this little pencil line that I have drawn on this image is actually a food line that I put on all these cases. And I keep it right away from the edge. I don't want to risk any trauma to those fragile, friable tissues. And I use the spoon end of my Lacron carver, put a food line into the model. The depth, of course, is going to be determined by the depth of the submucosa. And this is something you'll identify when you're looking in the mouth and pressing on the gum, so you'll know how deep you can go. And this is where you get your seal from. Because as I said, I don't want your obturator to be resting against the aperture of the cleft. I don't want the obturator being wider than the opening of the cleft. So the obturator literally sits in that space, and this food line seals it off. the obturator is not a retentive unit and it is not a sealing component. Junctional epithelium has to have limited or no contact with the base of the denture. At the insertion process, the procedure, the standard process of denture insertion is carried out. What I do with undercuts and also with these obturators is I'll often use either PIP, and this works really well for checking that we don't have any scraping or rubbing of the obturator against that aperture. So paint your PIP onto your obturator and then slide the denture in carefully as you normally do, and then take it back out. Ask the patient, did anything? No, that's great. But check where the slide pattern is, if any, on your obturator. And that's the area you need to remove. Continue this process until you can place that obturator into the mouth without it being wiped off onto the soft tissue. You can also use GC Fit Checker. And if you do adjust the obturator, again, back to the laboratory to polish it up because it's a non-keratinized mucosa. By doing this, we are only ever loading keratinized mucosa with unpolished surface, and our food line is our final seal. Again, ensure that there is no contact with the internal mucous membrane, which is unlikely if you follow these steps. You're not trying to fill the space. That is critical and probably something we don't realise. So there's quite a few take-home points. I hope I've covered them. I may not have, but that's why I've done these lists so that I can cover them. There should be no contact between the junctional epithelium and the obturator during insertion and extraction. Most important, we don't want to hurt the patient in this area. The obturator is polished smooth to protect the soft tissue for hygiene, to protect the soft tissue and for hygiene. These cranial spaces get very full of food and get very clogged up. At least we can put the denture back in a hygienic state. The obturator does not contact the mucous membrane of the inner cranial cavity. The base of the prosthesis is polished smooth at the junctional epithelium aperture of the cleft. The obturator is not a retentive unit or a sealing component. The large obturator may be hollow to reduce weight, but often your obturator will become much smaller than you think, given the aperture width of the cleft. The food line around the cleft acts as the same as the post-dam, only to isolate the cleft. I like to look at food getting under a denture much the same as putting money under your mattress. To put money under your mattress, you have to lift the denture. As you have to lift the mattress. To get food under your denture, you have to move the denture off the gum. And this will happen in normal function. And so some food will get under, but the better our seal, the better stability, the less food we're going to get. And the post-down or the food line may seal that off. Medication and risk of osteonecrosis needs to be managed during the planning and design of your obturator and your denture. Thinking about our submucosal cleft, the short, tight, soft palate is difficult to seal. You will get caught out and then maybe you'll realize what's gone on. I've been caught out recently in exactly this way. So it is something to reflect on when things aren't going your way. The V-shaped notch in the palate, remove it with caution from the denture base because it will lead to loss of suction, and it's probably the most common area. The technicians will polish it off so it's not sharp, but we'll lose our suction in the process. Use natural dentition for retention wherever possible. And this is something that the oral surgeons will be focused on heavily when they're doing their surgeries, whatever they can retain, they will, because it's going to improve your success for the patient in subsequent treatments. All standard processes, muscle balance, occlusal balance, retention, etc., is most important aspect to gain success. And really critical, as we know with interpersonal communication, determine the patient's goal for treatment and manage your expectations from the start, because the outcome isn't always what we were hoping for. Sometimes is, let's set ourselves up for success. And very important, and one I really can't hammer on about enough, we take good impressions, we take good records in the clinic, make sure that we make good models off our records, because this is going to lead to success. That was fairly quick coverage of what I think is important when making obturators for cleft palate patients. I hope it was clear. I hope I didn't get the presentation, but I'm happy to take any questions if anyone does have questions.
Thanks, Shane. That was an amazing lecture. Jebby, do you want to see if there are any questions? Check the chat as well for you. It was great to see about 14 participants join us throughout the talk. Unfortunately, a few had to leave, but Jebby, any questions?
Any questions, guys? Oh, yes, there's a question from Dr. Posolok.
Good evening, all. My question to Shane is that for patients in Papua New Guinea, most tend to have a habit of chewing betel nut. If you know what betel nut is it's much type of from betel nut.
Yes.
So in terms with obturators trying to prevent, especially betel nut, can you give us some pointers on how to prevent that? Not willing to give up based on that.
So I was breaking up a little bit. Is the question, is there any pointers on how to approach patients that have been treated for betel nut tumours? Is that correct?
Yes, for betel nut consumers.
Yeah. So
they
you,
were to
I'll try to answer the question. I couldn't. It was breaking up very badly. What I understand about betel nut, and you guys will know betel nut 1,000 times better than I do, but I understand that it leads to a thickening and shortening of the collagen in the soft palate. Is that correct? I can't hear anybody. But also, you know, it leads to oral cancer, as we know. I think my approach would be, and I don't actually know a lot about betel nut, is once the treatment for the oral cancer has been completed, and the patient is back in the general dentist's chair or my chair, I think proceed as per what I've just presented on. Do those patients then undergo post-treatment medication such as anti-angiogenics or bisphosphonate use?
No.
No. So treatment is purely surgical and maybe radiation or chemo?
No radiation in Papua New Guinea. Chemo, some.
Okay. I think, look, if it's purely if it's mostly surgical and some chemo, I think once the surgery is completed and the mouth is healed, it's very much not straightforward, but face principles again and develop your denture around that. That's an easy answer, but I don't know that I've actually addressed it well because I've not treated patients that have had betel nut, so I don't know what the mucosa ends up looking like after a severe case. Sorry.
Thanks, Shane. That probably leads on
Thank you
to
very
the
much.
next question. Oh, sorry, Postler. Probably leads on to the next question that I'd raise from like a surgical ablative perspective. If you're just looking at palatal defects, surgery-wise, there's a lot of soft and hard tissue changes for the few days, weeks, and even months post-ablation. And if there's no immediate reconstruction with a flap or a bone graft, how long what's sort of longest you'd wait before proceeding with your first obturator fabrication?
So what we will find if we say that there's different schools of thought. Some people will make an obturator to go straight into the mouth at the time of surgery. Other people will give it a time period to heal, and I would probably think around the 3-month mark to get our primary healing, primary bone turnover, and that's probably not. If we can deem that we've got soft tissue closure at that point, I'm happy to move forward, knowing that that denture is going to be a provisional appliance. Because I think we're going to get a lot of soft tissue changes and bone changes over the next 12 to 24 months. I'm not a surgeon. I pretty much work with plastic, but does that make sense to you, Johan?
No, that's great. Thanks. I guess the follow-on would be if you're thinking about provisionals in the 12 to 24-month mark, how often would you recall the patient to check on the appliance within that first 2 or 3 years following the ablation?
So I would be at initial insert, I will check that patient every week until I know there is no trauma being caused to the soft tissue. Once it's comfortable, it's stable, and everybody's happy, then I will let the patient go for 3 months. In the first 12 months, I will see them every 3 months. Temporary soft liners, whatever we need to do to make stability and keep the patient safe. Once it seems that the denture is stable, and I'm thinking 12 to 18 months for that, I would rather get them into a definitive full denture or a chrome cobalt partial.
Thanks, Shane. Before I do have a couple more questions, but I'll see if anyone else in the audience has something to ask. Jebby, surely you've got a question. I saw you writing down a few things before. Sorry to put you on the spot, mate.
Okay. Hello.
Yeah, we can hear you now.
No, I don't have any questions. Sorry, just
Okay. Okay.
I do have a question.
Right.
Can I ask all my colleagues in Papua New Guinea what impression materials are they generally using for their secondary impressions? Hello?
Hello.
I only ask this because in Australia we use a lot of PVS or silicons, but whilst we're at the university, we use a lot of zinc oxide eugenol as well. Because of its lack of elasticity, it's probably a little bit more difficult, or a little bit more caution needs to be probably given to how much pressure we put and how much zinc oxide eugenol we allow to go into the cleft space, just because it's a little bit more aggressive to get out if there's too much in there. Does that make sense?
Oh, yes, Narita, did you raise your hand?
Hi, just to answer your question. So in Papua New Guinea, we mostly use alginate for our primary impression, and PVS or silicone is not available throughout Papua New Guinea. So those that can be able to access it, they can actually use that for secondary impressions. Otherwise, mostly I think everyone uses alginate here.
Okay. And so zinc oxide is not used commonly either?
Yes, it's not commonly used here.
I really like alginate. I actually think there is nothing more hydrophilic than water. So alginate gives, personally, some of the best impressions you'll get. So that's nice to hear. That's really good to hear. I use, when I'm doing partial dentures or partial dentures with obturators, often I'll use my primary impression because it's as good as it's going to get. And if I've got all my extensions, we're going to get a good outcome with that. So thank you for that feedback.
Thanks, Narita. It's always nice getting the sort of feedback from the from my international colleagues about what protocols are used and what's available, because our experiences will always be different in different parts of the world, even different parts of the country. So that probably leads me to another question, Shane, if I may. Have you got any experience with sort of in your private practice, perhaps, making obturators for patients who are sort of off-site through digital scans, so like an intraoral scan, for example?
Not with intraoral scanning and digital processes. I think with a complete denture case, there is absolutely no reason why digital scanning is exactly the same as the traditional approach, because with our digital scanning and our impressions for full cases, we're definitely using our secondary impressions done the traditional way to create our digital models. So everything's the same to that point. And then it's just a digital protocol for making your denture. And you can, I'm sure, easily block out your digital model to prevent any occlusion with the of the denture of the cleft. I think it's pretty straightforward. I'm not a digital person. I do have 3Shape at work, like in my private practice, but I'm not completely there yet with the digital side. I do think your CT scans and your better digital programs will create a better obturator, or much easier. But we're scanning our impression, so there's absolutely no reason why it's not going to be exactly the same as if we did analog. And if we're doing intraoral scans of dentate or semi-dentate patients, absolutely, that can be done digitally without too much concern. Except, how do you scan? You're still scanning the impression. You can't scan the smaller cleft, surely.
No, that's a great point. I was just thinking about it from the perspective of the laboratory facilities, perhaps in some of the more regional or remote parts of Papua New Guinea, might not be able to fabricate prostheses that are a bit more complicated, and whether sort of off-site manufacturing would be a possibility. So, if a clinician and PNG went out into the community with some basic impression materials and a scanner, whether they could create something that could then be like an STL that could be exported to somewhere in Australia, have the prosthesis fabricated here, and then we only need to do minor adjustments in the field.
Well, I think definitely that's a scenario. But if communicating with the laboratory is an issue, it doesn't matter whether you're in Australia or PNG. So a scenario that I had, I asked for an obturator that was hollow, and when I got my final denture, the obturator was solid. Now, they had fortunately kept the aperture clear and polished, and that was great. But the denture was such that the weight of that obturator was going to make my denture drop in that area. So if you were with a technician that really didn't know how to make a hollow obturator, or wasn't totally sure about your obturation requirement, when you get your denture back, if there's contact with the aperture, you know to remove that. And we can see undercuts, we can see what we need to remove. That's not a big deal. If you then need to hollow out your obturator because it's just too heavy, that's also very easy, because what you simply do is get a round burr into your handpiece and make an access at some point in your obturator, and then just start to hollow it out in the clinic. And just hollow it all out until it's empty, until it's lost its weight. And then I simply sent that back to the technicians and asked them to occlude the gap that I just put in there. And that worked perfectly fine. The patient was super happy. If they were to make a hollow obturator and then put the two together, there's still going to be self-cured acrylic putting the two pieces together. So we've just got a little bit of self-cured acrylic closing the gap that I made. And that's a very viable option. If the technician's not that comfortable, just make it solid and then hollow it out yourself, send it back.
Awesome. Thanks for walking us through that.
Hopefully that was a help.
Yeah, no, definitely. Well, if there aren't any more questions, Jebby, do you want to close tonight?
All right. Thank you everyone for joining, connecting via Zoom for this lecture. First of all, I'd like to thank Mr. Shane Chambers. Thank you for your time, and thank you for agreeing to take us on with this lecture. Mr. Shane Chambers, I have his email address, so he's really keen on connecting with Papua New Guinea dentists and dental technicians. So if you want his email address or want to keep in touch with him, he also, you could go to his webpage, or I could also send you his email address. So just let me know if you want his email address. Thank you, Shane, for the lecture, and we hope that if any more lectures regarding your area or specialty, we would call you up again for another. On behalf of all of us, thank you, Shane Chambers.
Thank you, Jebby, and thank you, Johan. It's been a pleasure, and hopefully everybody's gotten something out of it. So thank you for inviting me tonight.
Thank you.
The pleasure's been ours, Shane. Thanks for coming.
Thanks.
All right. Also, if you have any requests for lectures, future lectures, you can also hit me up via WhatsApp or the email address provided on the poster, so we could arrange for other lectures also. Thank you all, and I think we're done for the night tonight.